How do I improve my shoulder internal rotation? And by that, I mean dealing with shoulders that have rolled forward and are not budging, no matter what drill I try. Perfect. So first, let's figure out what we're talking about from a visual perspective. What 612 IVO is talking about is someone who has a depressed chest, shoulders drooping forward, and likely a forward head posture. If I break that down for you, Degeneration X style, what that will entail and the way an internal rotation loss happens is as follows. If the chest is drooped forward, that means that the anterior thorax is concentrically biased. Stuff is short on the front. What that does is, if my hand is the sternum, is it depresses the sternum, it kind of pulls it down and back. When the sternum goes down and back, a common issue that is dealt with by Zach, the shoulder blades, the scapula, are going to round forward. That's going to be scapular abduction and internal rotation if my hands are the scaps, meaning that likely, although obviously this is going to be dependent on other compensations, the chest wall is going to be concentric and the posterior thorax will be relatively eccentric when you see this phenomenon. Now, if I round my shoulders forward, the humeri are internally oriented. Now, if my hands are in this position, I can't really do a whole lot, right? I can only give like upside down handshakes. And ain't nobody got time for upside down handshakes. So what we have to do in order for us to perform actions in our day-to-day lives is to right ourselves back to center. One common way that we do that is by externally rotating the humerus. No joke. If I externally rotate the humerus, that means the humerus is concentrically biased into external rotation, meaning I have concentric tension in muscles like the infraspinatus and no muscle finer than good old teres minor. If those muscles are concentrically biased into external rotation, you go to IR, you're going to have a limitation. Because if I'm concentric into ER, that pushes synovial fluid into the IR direction, and you can't create the shift in fluid. Therefore, you have a loss of internal rotation. There are other things that could potentially happen. Obviously, someone can have concentric actions in the posterior thorax, but if we just break down to how is shoulder IR lost, and we're not looking at anything else, it's concentric chest wall, shoulder blades round forward, humerus externally rotates to compensate so you can move your arms in a useful manner. So then, what you have to do to fix that, or to improve upon that, is to flip-flop that relationship. Really, the name of the game is to drive air into the front of the chest. Now, I want to caution you, 612 IVO, and all you other users. If you're thinking that, you're like your boy Big Z and you got the rounded forward shoulders, you got the forward head posture, that all of a sudden you're going to do this and you're going to have this nice, beautiful, sexy, upright posture. Your chin's going to be in line and everything's magical. False. That's not what happens. The degree that we can influence our static posture is going to be idiosyncratic. It's individualized. Because some of this, most of this, has likely structural and anthropometric influences. And you can only manipulate your structure to some degree. I'm built to be a runner. My chances of being a high-level bodybuilder are on the low, unfortunately. I've succumbed to that fact. Even though, I'm still going to be working on biceps, but like in terms of what I will excel at, it's probably not that sport. We can look at posture, static posture, in the same vein. Someone who has a forward head, rounded shoulders will only be able to change the static presentation so much. And I will caution you, I don't think the static presentation matters as much as you think, because we are not static creatures, even though this day and age makes us not move as much as we should. What is important is that we have all of our movement options available, because what that does is that will distribute forces more adequately across the body and allow you to perform better at higher levels, because you have more options available to you, and then tissues won't get overloaded. If I stay stagnant in any one position for a long period of time, I'm going to develop tissue ischemia in that area, meaning there's going to be a reduction of localized blood flow. That makes stuff cranky. If you are concerned about static posture, be more concerned about making sure that you're moving and grooving. That being said, we can still tackle pump handle. We can still drive air into the front of the chest to improve and influence our movement options. This may lead to some changes in posture, and it can definitely lead to some changes in your WAC internal rotation measures. How do you do that? Well, I'm glad you asked, because what you do about it depends on your structure. Are you a narrow infrasternal angle, or are you a wide infrasternal angle? I have a detailed post that talks about how this will, or what the infrasternal angle is. It will be linked in the show notes, which will be found on zachcouples.com/shoulder-internal-rotation. So check it out if you're watching this live. Go ahead and check that out, because I actually write like full blogs to summarize this. And I think you'll learn better if you watch it, you listen to it on the podcast, and then you read it. That way you got 3 different ways to get your learning gains on point. So check out the show notes. Driving air in the front depends on infrasternal angle presentation, because the reason why a person is restricted is different for each ISA presentation. The first one I'm going to talk about is a narrow infrasternal angle. So if you're a narrow ISA, chances are you have an ISA that we'll say is 100 degrees or less. A narrow infrasternal angle has a concentric anterior thorax as part of the structural bias that that person has. With a narrow ISA, they're going to have a relatively counternutated sacrum, meaning the sacrum is going to be tipped back, so that person, from a chances of where they're going to fall perspective, is more likely to fall backward, because when the sacrum counternutates, pelvis tips back, you don't want to fall. So the first line of defense against that structural bias is to concentrically bias stuff on the front side of your body. Hence, the pump handle restriction, or the concentric anterior thorax. In order to improve this restriction for a narrow ISA, you need to make the structure dynamic. Meaning, if I'm a narrow ISA, that means my side-to-side dimensions of my rib cage are reduced, so they're smaller, hence the narrowing of the rib cage. So you got to do things to blow out the sides. In order to blow out the sides, you need to decrease the anterior and posterior dimensions. A great way to do that is by reaching straight forward, 90 degrees of shoulder flexion. When I reach at about 90 degrees of shoulder flexion, what that's going to do is it's going to drive the scapula, the shoulder blade, into external rotation, meaning the posterior thorax is going to be more concentrically biased. So that's going to push air into the front. Now, you're also going to get some degree of concentric bias on the front side of the chest because of pec activity, but in terms of where the tug-of-war wins, it's still going to win with more restrictions posteriorly, more air anteriorly. This is especially true if you choose an activity like a lazy bear, which, if you don't know what that is, that would be basically on hands and knees, a quadruped position. With that particular exercise, now you have gravity pushing things down, meaning when you take a breath of air in, more air is going to go into the front of the chest. Life is good. Because of that position, reaching forward, you get relative A to P compression of the rib cage, which will allow for lateral expansion of the rib cage, increasing the structural dynamics. And if you choose something like quadruped, you can use gravity to push more air in the front. You do that, and guess what, folks? You're going to have increase in anterior thorax expansion, and that can influence the scapular positioning that we've been talking about. That is a little bit different when it comes to a wide infrasternal angle. Wide ISA, someone with an ISA greater than 100 degrees, we'll say. For this person, the restriction in anterior thorax expansion is a secondary compensation. I'll link stuff talking about primary and secondary compensations in the show notes. Meaning, the structural influence is a bit different. If I'm a secondary compensation, for a wide, their first instinct, because the sacrum is relatively nutated, is to fall forward. So their first line of defense is to concentrically bias the backside of the body. If that pulls me too far back, then I'm going to need to do something to concentrically bias the front side of the body. That's where you get your pump handle restriction, or your concentric bias of the anterior thorax. For this person, you still have to respect the underlying structure. If I choose the quadruped exercise I talked about and I reach straight forward, that's going to concentrically bias the backside and the front side to some degree. Meaning, guess what? You're going to get lateral expansion of the rib cage. The wide infrasternal angle doesn't need that because they're already expanded laterally. You got to do things to squish the sides so you get greater A to P expansion. Think John Belushi in Animal House. I'm a zit. Got it? Guess what pushes the mashed potatoes out of your mouth in this case? It would be in the upper thorax, the serratus anterior. Now, if I were wanting to increase concentric activity in the serratus anterior, what would I do? Well, by golly bows, I'm going to need scapular upward rotation and protraction. A great direction to create that reach would be about 110, 120 degrees of shoulder flexion. That's going to bias more scapular upward rotation. It's going to give the serratus anterior leverage to squish the sides of the rib cage, allowing you to get A to P expansion. So you're still putting some respect on the name of that person's structure. Narrow ISA, I want to reach forward to get pump handle. Wide ISA, I want to reach 110, 120 to get pump handle. Of course, folks, that you are stacking, right? If you aren't stacking, you're not talking to Zach in. So make sure you have that first. So stack, reach based on what the ribcage structure tells you. That's step one. Step two, another way that you can get expansion in the front of the chest would be with anything that involves scapular retraction and shoulder extension. Because if I'm pulling my shoulder blades back like a row, that means I'm going to have more concentric bias in the back side of the body. More air is going to get pushed in the front. I usually start with the forward reaches that I talked about first. Then if someone's still limited in IR and they look good from a stacking perspective and a reaching perspective, then I'll go with something like that. To summarize, so far, what you got to do is reach depending on what ISA presentation you're dealing with. Narrows are going to reach forward, wides are going to reach at 110, 120. Finish the job with some scapular retraction stuff, and you should have some air in the front of your chest and life should be good. Asterisk moment. Unless you have some issues with the upper airway. Because another reason you could have a concentric anterior thorax may be because the forward head position is driving the pump handle down. One may attain a forward head position because of an inability to nasal breathe. And this can be for a wide variety of reasons. You could have a local nasal restriction. You could have a high palate. And a high arched palate will compromise the floor of the nose, and that can make the airway restricted. There could be restrictions in the throat, lots of different possibilities. If you want to learn more, I would definitely check out the myofunctional therapy post that I did. And also, too, when I release the podcast with Dr. Hockel, I'm hoping that comes out this upcoming week. Check that out. It's going to be Airway Orthodontics with Dr. Hockel. That will also go into great detail in terms of where potential restrictions in the upper airway can be. But if for whatever reason you can't breathe through your nose, what can happen is your tongue posture will drop down and back, decreasing space in the throat. That will allow you to better mouth breathe. Because if you can't get air through your nose, you still got to breathe. So if the tongue sits down and back as opposed to up on the palate, well, now I can breathe through my mouth. Life is good. But the issue is when I do that, and the tongue sits low, the jaw gets pulled back, which decreases the airway space. So guess what you can do as a wonderful compensatory strategy to make sure that you get air in through your mouth? You can shoot your head forward, which is OA extension and lower cervical flexion. That position increases the airway dimensions in the throat. That's one reason why when you're giving CPR to someone, you tip the head back, is because it increases the airway dimensions. So there are obviously a lot of different ways you can impact upper airway positioning, depending on what you're dealing with. And it goes beyond the scope of what I can talk about in a debrief, because it really does require a thorough evaluation of a lot of different influences. But from a movement perspective, the two #major keys that you can focus on would be teaching yourself to attain a palatal tongue posture, tongue on the roof of the mouth. And then two, the other thing would be working on swallowing, because when you are in this forward head position, the hyoid, and it's different if you have multidirectional restrictions, but the hyoid is more depressed. When you do swallowing exercises, that can elevate the hyoid and return things to some semblance of normal. To attain a palatal tongue posture, because you need that first, you need to be able to place your entire tongue on the roof of the mouth. I want y'all to join with me. Say the letter N. Go ahead, do it. I can hear you on IG saying it. So when you say the letter N, think about where the tip of your tongue hits. The tip of your tongue is going to hit just right behind the front of the teeth. It's called the rugae. So that's where you want the tip of your tongue to be resting. From there, you want the rest of the tongue up into the roof of the mouth. If you want to practice that, you can go ahead and cluck yourself. If you make a clucking noise like that, the posterior tongue or the backside of your tongue will be contacting the back of the roof of the mouth. So once you can get your tongue there, you may simply just work on opening and closing, which is tough for me right now because I got my appliance in my mouth, but that. Once you can attain a palatal tongue posture, your next course of action would be to work on swallowing. So can I keep that tongue posture, put some luscious Topo Chico in my mouth, and swallow without jutting my tongue forward? If you do that, hyoid's going to be elevated, life will be good. Summarize the treatment possibilities. First and foremost, get air in the front of the chest. It's different for a narrow, different for a wide. Narrows are going to reach forward, wides are going to reach at 110, 120. You can clean up after that with some shoulder extension and scapular retraction. Also make sure you're checking tongue posture. Tongue's got to be up on the roof of the mouth. And make sure you work on your swallowing skills, because forward head posture often accompanies a concentric anterior thorax. Awesome question, 612 IVO.